Okay.
Okay, good morning, everyone. Allow me to introduce our guest speaker of the day, Prof. Nazaruddin. Prof. Nazaruddin is a consultant neuroanesthesiologist and neurocritical care specialist. He's currently the head of Department of Anesthesiology in HUSM. He did his neuroanesthesiology fellowship in University of Toronto in 2009 and was promoted to associate professor in 2018. Prof. Nazaruddin has an impressive list of publications in indexed journals. His research areas include neuroanesthesiology and neurocritical care, general anesthesiology and critical care, total intravenous anesthesia and target controlled infusion, and ultrasound-guided peripheral nerve block. Today, Neuroemergency Medicine Special Interest Group is honored to have Prof. Nazaruddin to spare his Saturday morning to share with us a CME entitled The Swollen Brain, Increased ICP Management from Neurocritical Care Specialists. Prof, the floor is yours.
Thank you to Dr. Chow for a very kind introduction. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to all dear listeners and participants for today's CME. So it is, I'm honored to be invited to this CME organized by Neuroemergency SIG. It is a very good move by the ED group to form the SIG so that there will be a group that will be focusing on neuroemergency. Okay, the topic given by the organizers to me is on the swollen brain high ICP management. So what I'm going to talk is based on my experience and as well as my references related to the topic given. Okay, I would like to declare that I have no conflict of interest in any parts of the presentation. And the discussion is mainly based on the references and my clinical experience as a neuroanesthesiologist and neurocritical care specialist for about 12 years. Okay, so within this 1 hour presentation, we will go through briefly refresh our knowledge on the physiology of ICP, pharmacology of drugs related to CNS and ICP effects from the drugs that we commonly use to manage ICP and the patient related to head injury. And we're going to go through the sequence of management at the pre-hospital level, followed by emergency department, operation theater, as well as in neuro ICU. Okay, let's start briefly with the physiology of ICP. I think most of us already know, but we need to refresh to understand about our discussion about today's topic. Okay, the physiology of intracranial pressure, as we understand that this is a pressure within the rigid skull, which is generated by the contents within the skull, mainly by the brain, CSF, as well as the blood within the skull. So this is basically the normal value is about 5 to 15 millimeter mercury in supine position, and the ICP is actually varies cyclically with respiration as well as the cardiac cycle. And in the normal physiology, ICP will have changes. It can fluctuating up and down in certain situations, like when we change our posture. Lowest in the upright position, okay, but the one that we given 5 to 15 millimeter mercury is in the supine position. And whenever we have a coughing, sneezing, and straining, ICP can be increased up to 45 millimeter mercury. So this is very important as well when we managing the patient with high ICP, when patient gagging, and when patient coughing. So it can fluctuate up to 45 millimeter mercury basically. And at the same time, when we managing the patient in our clinical setup as well, any stimulation to the sympathetic stimulation, such as for our intubation, surgical stimulation, and so on, ICP also can be increased, can be fluctuate up and down, okay, with the changes and the stimulation given by us. Okay. Other than that, we need to remember the relation between ICP and the Monro-Kelly hypothesis. So, Monro-Kelly hypothesis mentioned about the volume of the brain and its constituents inside the bony cranium is fixed, basically, and cannot be compressed. So the contents, as we know, is about 85% of the brain volume, CSF about 10%, and blood volume about 5%. And to prevent the constant pressure in the cranium, so the volume of the content must be maintained. So we must maintain. So is there any increment of the volume of any part of the content? So if we want to compensate an increase in ICP, we need to remove some of the volume from the components of within the skull. So this is the Monro-Kelly hypothesis that we used to know in our physiology chapter. And then another important thing is that we need to understand about the regulation of intracranial pressure. We must remember about a pressure-volume relationship between ICP and intracranial volume. So whenever is there an increase in the blood, for example, bleeding, ICP will increase. We have a compensation at this stage. Body try to regulate by CSF translocation and increase the absorption rate to prevent from further increase of ICP within the skull. But subsequently, when the mechanism has been exhausted, the intracranial pressure keep on increasing with an increase in the volume in the brain. So at this point of view, we need a external mechanism of management to help to reduce the ICP. If not, then if we don't do anything in terms of clinical management, so we can see the ICP keep on increasing with the increasing of the volume until at a certain point it can midline shift and so on. So this is what happening in the brain in relation between intracranial pressure and intracranial volume. Right. So another important aspect of physiology that we need to understand about the relationship between cerebral perfusion pressure and intracranial pressure. As we understand that CPP is pressure driving the flow of the blood through the brain. And we must remember this is very important equation, MEP minus ICP or cerebral venous pressure. We often misunderstood CVP. We refer to central venous pressure, which is at the internal jugular vein, but actually the more accurate is cerebral venous pressure in the jugular bulb, which is mainly the venous pressure from the brain without mixing with other part of the body. So actually any of increment of ICP or CVP should be with the differences with the MEP. So we get cerebral perfusion pressure. So normally it should be 60 to 70 millimeter mercury. We try to maintain the cerebral perfusion pressure to maintain the driving flow to the blood. And if CPP too low, our brain can have ischemia, and if too high, more than 50 millimeter mercury, we can have cerebral edema. So we taking 150 millimeter mercury and we refer to MEP, the auto-regulation between 50 to 150 millimeter mercury. And any factors that affecting cerebral perfusion pressure, like changes in MEP, ICP, or cerebral venous pressure, can change the cerebral perfusion pressure. Okay. Another important aspect we need to remember the relationship between intracranial pressure and cerebral blood flow. So this is very important. Any cerebral vasodilation will cause an increase in intracranial pressure, and so many factors that can affect cerebral blood flow. For example, our metabolic like PaO2, PaCO2. So we can see PaCO2 is more linear relationship between cerebral blood flow. Okay, between 35 to 40 millimeter mercury. So we can see if PaCO2 hypercarbia, we can see cerebral flow will linearly increase. So like hypoxia as well, at the level of 50 millimeter mercury, when hypoxic, we can see then cerebral blood flow will increase because cerebral vasodilation to improve the perfusion to the brain. So this is another important thing, where cerebral vasodilation ICP also can be increased. Okay. At the same time, we must remember about the mean arterial pressure, 50 to 150 millimeter mercury, where the brain has the mechanism of auto-regulation to maintain the normal flow to the brain, even though MAP keep on increasing. So this also influence the cerebral perfusion pressure. So this also very, very important related to ICP management, ICP changes in the brain. Another important physiological thing is that CMRO2, cerebral metabolic rate of oxygen consumption, where the cerebral blood flow has a coupling mechanism with the cerebral blood flow. As an increment in the CMRO2 will increase in cerebral blood flow, for example, in condition like hypothermia or seizures. Okay. There's a few important things that we need to remember as a revision. And another part, we need to remember about a few important drugs which has an important effect to the central nervous system. Okay, we look at this. Okay, we need to look at the few ideal properties for sedative and analgesic agent for neurotrauma patient, which is actually related to intracranial pressure. So we need, if we have the agents, the drugs, they have quick onset and offset, predictable clearance, dependent of an organ function, easily titrated to effect. We can reduce ICP, can reduce the blood flow and CMRO2, but maintains blood flow and CMRO2 coupling, and maintain autoregulation, minimal cardiovascular depressant effects. So especially in other factors, but this is another. This is a list of important criteria for drugs that is very useful in the neurotrauma and patient with intracranial hypertension. So this is the list of drugs that commonly we use. Okay, this is a list of drugs. We can it can be used as sedation and analgesia, but commonly we use, we can see like a fentanyl in our setup. Okay, remifentanil is one of the good drugs that one of the good analgesia in intracranial hypertension. Thiopentone, propofol, dexmedetomidine we also use. Ketamine has been discussed about the benefit and the risk of using ketamine as well. So this is the common list of drugs. But the most important thing I would like to highlight, this is the ideal properties of the drugs that we can use for patient with high ICP. Another important thing that I need to highlight is that we need to look at the CNS effect of this drug. For example, we look at propofol and barbiturate. So the drug that has a cerebral protective properties is the drugs that can reduce the intracranial pressure. Okay, the drugs that can reduce cerebral blood flow and CMRO2. We can see that barbiturate and propofol are markedly reducing the cerebral flow and CMRO2, and some of the books mention that barbiturate has more markedly reduction of CMRO2 than propofol. If you look at benzodiazepine, it has some effect to the CNS, but just less if compared to propofol and barbiturate. If you look at the ketamine, we can see the ketamine into of CNS effect. It can cause an increase in ICP, increase in cerebral blood flow. But in this book that I referred to, it mentioned that no effect to CMRO2, but it like opposite to propofol and barbiturate. You look at the opioids mainly. Opioid doesn't have much effect on ICP, CPP, cerebral flow, but slightly reduction of CMRO2. Okay. At the same time, we must look at the effect of this drug to the cardiovascular, because it will affect the cerebral perfusion pressure, because it affects the mean arterial pressure. We can see barbiturate and propofol, as we know, causing hypotension because it got vasodilatation effect. Okay, if compared to benzodiazepine, opioids, and ketamine increase in MAP because it causes vasoconstriction. All right. Okay, this is just briefly because along the way in our discussion, then we need to refer back to our physiology as well, the pharmacology. Okay. Okay. This is the group that has a risk of intracranial hypertension. As we remember in our clinical practice, the traumatic brain injury, any hemorrhage, subarachnoid hemorrhage, intraparenchymal hemorrhage, cerebral hemorrhage, ischemia also, patient got massive stroke, increase in the cerebral edema, also increase in ICP. This is the example of the patient at risk to develop acute intracranial hypertension who may benefit with the ICP monitoring. And if the ICP increase very markedly until very high level, it can cause herniation. So when herniation happen, then possibly the prognosis become worse and worse. We can see there's many types of herniation, like transtentorial, okay, descending unilateral, descending bilateral, transtentorial ascending, go upwards, and subfalcine cingulate herniation, as well as tonsillar herniation and foramen magnum. So all these different type of herniation can manifest in the different clinical manifestation. But at the end, the most important thing, when the herniation happen because of increase in intracranial pressure, the outcome and the prognosis become poorer to our patient. Right. Another important aspect that I will highlight along the way of my presentation is that I will refer to the Brain Trauma Foundation Guideline 4th edition. This is actually the guideline developed by American Association of Neurological Surgeons, based on the 189 publications, and they reviewed as an evidence-based management, and they put it in the few levels of recommendation. The good one is level 1, based on high quality body of evidence, and most of the recommendation from the review, we got about 38 recommendation. Is most at the level A to level 3, which is level A is moderate quality, level B is low quality, level 3 is at the lowest end of quality. But I think this is recommendation made by very established body, and we always we can refer to in terms of management of severe traumatic brain injury and directly related to management of intracranial pressure. So in general, goals of the therapy for acute intracranial hypertension, firstly, we need to manage the primary insult. Okay, any bleeding, primary insult, we need to handle that primary insult, aiming to reduce ICP less than 20 millimeter mercury, and aiming to maintain cerebral perfusion pressure at the level of 60 to 70 millimeter mercury. And at the same time, we're managing a secondary insult to prevent from further worsening of the injury by maintaining a good oxygenation. PO2 about is at least minimum PO2 more than 60, but we need to put higher, which is better. 80 to 100 millimeter mercury is better. Maintain normocapnia, which is PaCO2 35 to 40 millimeter mercury. Maintain normotensive with the auto-regulation range of MEP between 50 to 150 millimeter mercury. We should maintain normoglycemia, because hypo and hyperglycemia is actually bad to the brain. And we need to maintain normal MRO2. This is actually preventing something like a fever, seizures, as well as using drugs to maintain a normal MRO2. And we try to prevent cerebral vasodilation. Okay, this is a general goal of intracranial hypertension. So one of the Brain Trauma Foundation guideline mentioned about intracranial pressure threshold. So the recommendation to treat ICP when it reached above 20 millimeter mercury, because the value above 22 millimeter mercury will increase the mortality. This is the number 9 recommendation. Another recommendation listed in the Brain Trauma Foundation guideline is about putting intracranial pressure monitoring. So if we can put ICP monitoring with the management guided by ICP monitoring, the management of severe TBI can reduce in hospital and 2 weeks post-injury mortality. Okay, this is the guideline is actually released in 2016. They will review every 10 years, basically. Another important recommendation, this is level 2B recommendation about cerebral perfusion pressure monitoring. Okay, so the management of severe TBI patient using guideline-based recommendation for CPP monitoring is recommended to decrease 2-week mortality. So always very important for us, either ICP guided and CPP guided management along the ways. It doesn't matter at the ED department, at the ED management until the neuro ICU management. And about the recommendation for CPP threshold, the recommended target CPP value for survival and favorable outcome is between 60 and 70 millimeter mercury, where the 60 or 70 millimeter is minimum optimal CPP threshold is unclear and may depend upon the patient's autoregulatory status. So this is basically they put it 60 to 70 millimeter mercury to maintain the CPP so that the driving pressure to the brain is maintained. Right. Okay. So avoiding aggressive attempts to maintain CPP above 70 millimeter mercury with free and pressure may be considered because the risk of cardiac respiratory failure. So this is if we look at the CPP alone as the isolated value, but if you look at the patient as a whole, we have to look at other factors as well. And then we too aggressive, putting the free bank, all the free and pressure sometimes, aiming the CPP with the MAP very high and the situation all IO balance and so on. It also we need to anticipate the possibility the complication might raise from that because of the cardiac respiratory failure. So this is very important as well. So as a whole, we must remember that ICP management is a multidisciplinary management. It needs to be managed at the emergency department level. It should be managed by the radiologist, anesthesiologist, neurosurgeon, rehabilitation physician. So this is multidisciplinary to help our patient with high ICP. And at the same time, we must remember the management of ICP is multi-level clinical management. It's not only multidisciplinary, it's a multi-level. So we need to focus on the pre-hospital management. We have to focus on ED management, and followed by operation at the operation theater and ICU care. So at any point, we must be synchronized in our management along the line so that we want the prognosis, the outcome of our patient is good. Okay, we look at the pre-hospital management. This is the common scenario. A 20-year-old man who is a motorcycle rider without helmet is found at the roadside by passerby and is suspected to be a victim of hit and run case. He's unconscious but still has a regular breathing. The nearby hospital is called for emergency rescue management. So this is we go along with the scenario. This is at the pre-hospital management. So what is the important ICP management at this point is actually if patient is poor GCS less than 8, the most important thing is for securing the airway. So we need to, if securing the airway, we need to think of some form of induction, depends on the conscious level, on the requirement needed, and the intubation itself is very, very important management of ICP management. So why we need to secure the airway with GCS less than 8 because of airway protection. So when GCS very poor, the airway protective reflexes very poor and patient tendency to have aspiration. So we need to protect the airway. And at the same time, because possibly labored breathing from the patient tend to develop hypercarbia, patient tend to be hypoxia, which, as we discussed earlier, physiologically it can worsen the brain condition from the primary insult. So during the intubation, very, very important, we choose IV induction that has cerebral protective and less hypotensive effect. So we have to look at the condition of the patient. Okay, we can use whatever familiar agents that are available for at the district hospital, or if available propofol, you can use either titrated dose or midazolam. Okay, and then with the fentanyl anesthesia. A rapid sequence induction is very important, even though we can use succinylmetonium. As we know that succinylmetonium can cause a transient increase in ICP. But because of during the process of intubation, we can provide a little bit hyperventilation. We can counteract the effect of transient high ICP during the intubation using succinylmetonium. Because succinylmetonium is useful when the patient in the trauma patient, when we assume that patient full stomach and risk of aspiration is there, we need for rapid sequence induction. We can use rocuronium as a modified rapid sequence induction as well. It's no issue. And at the same time, it's very, very important to obtain the sympathetic reflexes before intubation. So this is actually the regime normally used in operation theater. We put either we give IV Osmolar 0.5 mg/kg or IV Inocan 1.5 mg/kg to obtain the sympathetic reflexes, because our intubation normally can raise the heart rate and blood pressure shoot up, can be more than 150, which is in this scenario when patient in the freshly injured, traumatic brain injured, then we try to avoid from worsening the bleeding and secondary insult. And smooth intubation is very, very important in this condition. And at the same time, this is very important reminders that if we don't secure the airway, patients tend to have aspiration. Then normally, when I reviewed the patient in neuro ICU, sometimes when patient aspirated, so always mix up the diagnosis between aspiration pneumonia or aspiration pneumonitis. So most of the time, our medical officer put the diagnosis as aspiration pneumonia. But actually, in the poor airway reflexes, for example, in our patient traumatic brain injury, poor GCS, okay, whether weakness or being weakness or unweakness, the aspiration, but most likely at the moment, if the chest X-ray showed the evidence of aspiration, is more on aspiration pneumonitis, okay, when the aspiration of sterile gastric content in the large volume, okay, then we can look at the chest X-ray more on the right side, and then causing the hypoxemia. So this is more at the beginning, the acute stage of trauma. This is most likely on aspiration pneumonitis, where at the end, it can develop secondary infection later on, possibly. But aspiration pneumonia, basically more on the micro aspiration that happen possibly in patient with dysphagia or gastric dysmortality. It's a micro aspiration, or like in patient in ICU, got micro aspiration from the oropharyngeal secretion and so on. This is can be aspiration pneumonia. So most likely it's a more aspiration pneumonitis. It can be severe, depend on the pH of the gastric content. It depends on what actually the content that being aspirated by the patient. Sometimes if food particle also being aspirated, then the risk, the injury, the inflammation to the lungs is more severe. So the right diagnosis is very, very important, because when aspiration pneumonitis, we might need to have a bronchoscopy. And this patient with aspiration pneumonitis, which is a chemical injuries, chemical pneumonitis to the lung, is actually one of the top causes of ARDS, which patient might develop later on in neuro ICU. Okay. And the next one, when a patient has been intubated, we need to manage putting portable mechanical ventilation. Always maintain the aim to maintain good oxygenation. If we need to put PEEP, if not necessary to put very high PEEP, then we try to avoid, because studies show that PEEP more than 12, actually less than 12 is acceptable, still negligible, the effect to the ICP. But if more than 12, very high PEEP is possibly can slightly increase ICP. But if actually high PEEP is indicated in the patient with ARDS, traumatic brain injury with ARDS, what we have to apply PEEP, because if we don't apply PEEP, then patient can develop hypoxemia. Also, the vicious cycle will worsen the brain injury. And at the same time, we try to keep normocapnia. So if we need to manually ventilate patient, so we must avoid hyper or hyperventilation, because both hypocapnia and hypercapnia is actually not good for the brain. So for the ventilation therapy, Brain Trauma Foundation guideline also mentioned two recommendations. One of the recommendation is actually mentioning about prolonged prophylactic hyperventilation with partial pressure of carbon dioxide in PaCO2 of 25 millimeter mercury or less is not recommended, because less than 25 millimeter mercury can cause cerebral vasoconstriction, is actually worsen the ischemia. And hyperventilation is actually recommended as a temporary measures for the reduction of elevated ICP. We can use a transient hyperventilation to reduce partial pressure of CO2 in a short duration to respond to acute intracranial hypertension. So it should not be prolonged. Okay, hyperventilation should be avoided during the first 24 hours after injury, when cerebral blood flow is often critically reduced. So this is very, very important reminders in the recommendation. What about blood pressure threshold? Brain Trauma Foundation guideline also mentioned about maintaining systolic blood pressure at more than 100 millimeter mercury for patient 50 to 69 years old, or at more than 110 millimeter mercury or above for patients 15 to 49 or over 70 years old, may be considered to decrease mortality and improve outcomes. So controlling the blood pressure is very, very important as well during the management of patient with high ICP. Another important ICP management measures, this is even at the pre-hospital level, fluid therapy, which we need to remember giving IV fluid is very, very important as well, but choosing the type of IV fluid is very, very important as well. So the recommendation is for isotonic crystalloid solution. If we have a balanced crystalloid solution, balanced isotonic crystalloid solution is better, like sterofani, for example. And sedation, we must provide some sedative agent that has a several protective effects. So most of the recommendation mentioned about propofol infusion and fentanyl, which is easily available. Even though to me remifentanil is better, but remifentanil is not available in all hospitals, and in some hospital also it need to be paid by patients, and it's a little bit expensive. So propofol infusion and fentanyl is a reasonable combination of sedative and analgesic agents. And alternative, if I think at the pre-hospital level is not familiar, and then we can accept midazolam and morphine infusion. If at the pre-hospital level they are not familiar with these drugs. So at the same time, head up position 30%, about 30 degrees is very, very important to maintain the drainage of the venous drainage, and this is part of important physiological measures to prevent from an increase or further increase in ICP. And at the same time, avoid any neck compression or jugular venous drainage is very, very important as well. During transportation from the pre-hospital, the transporting to the tertiary hospital, for example, continuous monitoring is very, very important. This is basic things: SpO2, got end-tidal, ECG, and IBP, and keep cerebral protection. Okay, avoiding maintaining all the physiological goal that has been mentioned earlier, and as well as starting the appropriate sedation and anesthesia. This is very, very important. And starting a vasopressor also is very important to maintain cerebral perfusion pressure. It's not because of patient in shock or hypotensive, but if you need to maintain CPP around 60 to 70 millimeter mercury, so the advice is actually you can start vasopressor, which is noradrenaline infusion. It is the first vasopressor, the vasopressor of choice for us to maintain the cerebral perfusion pressure. And the ED management, if patient is transferred immediately to the tertiary center for further investigations and management, immediate scan of brain shows multiple brain contusion with cerebral edema. So if the same patient at the ED level, so the same thing that we need to aim: reduction of cerebral blood flow, reduction of CMRO2, and reduction of ICP. So sedation need to be started, or if has not been started at the pre-hospital level, need to be started at the ED for cerebral protection and to facilitate mechanical ventilation. I still recommend propofol and fentanyl infusion. Keep normothermia. We should start the seizure prophylaxis earlier. Commonly, our neurosurgical colleague will start phenytoin. Maintain CPP, outline if possible, so that we can monitor the beat-to-beat variation of blood pressure, so that it is very important to guide our cerebral protection strategy. CVP, we need noradrenaline infusion. We can insert the central venous pressure. It's good for us to administer the vasopressor, and fluid management is very, very important. Isotonic crystalloid solution, and the best we can have balanced solution. So for mechanical ventilation in ED as well, the same goals: avoid hypoxia, maintain normal capnia. We try to correct the anemia and coagulopathy. If patient anemia, if we don't correct, so the oxygen delivery will be affected, so it will affect the brain as well. Okay, and the most important thing at this point, while we're doing the cerebral protection, while optimizing, avoiding the secondary insult, at the same time we try to optimize and prepare the patient for surgery as soon as possible, so that if we can expedite the management towards the early surgery, the outcome of the patient possibly will be better. So this is a specific therapy for acute intracranial hypertension. Let's say suddenly we can see patient worsening, should a sign of suddenly further increase in ICP. So we can think of immediate therapy for the acute intracranial hypertension by giving transient hyperventilation. So hyperventilation basically will increase the ventilator rate about 30 to 40 breaths per minute, and increase minute ventilation within slowly within 15 to 20 minutes, so that we can aim of PSO to about 26 to 30 millimeter mercury. So this one actually because of cerebral vasoconstriction, so that we can our goal is to reduce ICP abruptly. At the same time, we cannot prolong the acute hyperventilation. So we have to wean slowly. If let's say a patient in the refractory intracranial hypertension, we have to wean slowly. If not, it can cause a rebound high ICP. At the same time, this is our goal for decompressive surgery. Decompressive surgery and putting the EVD for monitoring and draining of CSF. Okay. At the same time, this is another first-year management. We can choose a hyperosmolar therapy, either mannitol or hypotonic saline. We can see the mechanism of mannitol is reduce the brain water, reduce RBC viscosity, increase the blood flow, free radical scavenging, reduce SF production as well. So mannitol is more commonly used. You can give, I think the dosing, people have been familiar with 1 to 2 grams per kilogram every 4 to 6 hours. But we must remember there is a limit also with the mannitol. Okay, mannitol also can cause a reduction in the blood pressure because of diuresis. So we must be aware of the side effect as well. Another option is hypertonic saline. Hypertonic saline is one option because in terms of hemodynamic and maintaining the volume, it is better. But it is you can either give 3% normal saline, or in neuro ICU sometimes we use 7.5% of normal hypertonic saline. In some centers they use up to 23.4% hypertonic saline. So it can be used because this is we can see the higher concentration of hypertonic saline, they got higher osmolarity, so the sodium concentration also is higher. So actually, basically, it depends on the institution. It can be used either 3% up to 23%. So normally, if we use very high concentrated, we use lower volume. But it is useful to have as a hyperosmolar therapy, as well as to prevent sudden drop of blood pressure as well. If we compare between mannitol and hypertonic saline, you can see this is the dosing. The most important thing is that augmentation of mean arterial pressure is moderate, but this hypertonic saline, it can augment the mean arterial pressure as well. This is very, very important. And then when we give mannitol, we should expect some increase in serum osmolality, which is the limit of mannitol. We cannot exceed 320 milliosmol per liter when we treat the patient with mannitol. But for hypertonic saline, we can go up to 360 milliosmol per liter. So this is one of the important aspects when we're using either mannitol or hypertonic saline. Right. Okay, this is one of the recommendation. PhD has been supported in the 3rd edition, but it's not more supported in the 4th edition. Okay, although hyperosmolar therapy may lower ICP, there was insufficient evidence about effects on clinical outcomes to support the specific recommendation or to support the use of any sort of hyperosmolar agent. So actually, the evidence is insufficient for the usage of hyperosmolar therapy. But clinically, we have been using that. Okay, we have been using hyperosmolar therapy as a part of our ICP management. All right. Okay, now why? Okay, we move to the OT management. Operation theater management is very, very important. If you remember at the pre-hospital management, just now the goal is the same. At the ED management, the goal is the same thing. In the operation theater, the patient is planned for emergency decompressive cranectomy and EVD insertion. So the same thing is very important. During anesthesia, we should maintain the CPP between 60 to 70 millimeter mercury, avoid secondary insult, cerebral protection. And normally in the patient with high ICP, we use total intravenous anesthesia using in combination propofol and remifentanil. And hyperosmolar therapy normally given before we opening the dura. And the principle of surgical management, so immediate surgical release of ICP by decompressive cranectomy and putting EVD for ICP monitoring and CSF drainage in neuro ICU. So this is actually we use total intravenous anesthesia. We use the same drug propofol, and if we don't have remifentanil, we use fentanyl infusion. But the ideal one, we use propofol and remifentanil. We don't use volatile agent, because volatile agent can cause. We try to avoid volatile agent, even though we can use up to the certain limit of minimum alveolar concentration is about 1. But the best cerebral protective agent, we try to use total intravenous anesthesia. Normally in operation theater, we use the special infusion pump. We call it TIVA, target control infusion pump. Just introduction to our ED colleagues that propofol can be delivered with the special pump, where propofol and remifentanil can be delivered with the special pump, where they got the software comprises of the pharmacokinetic profile of propofol and remifentanil, where we just did like this one, propofol got the, this is for pediatric basically, propofol got MASH model and Schneider model, where remifentanil they got Minto model, where we just set the target, how much we want to deliver to aim certain target, like 4 microgram per minute of propofol in the blood. Then we set based on the model, based on the age, based on the body weight, and then the pump will deliver a certain amount of drugs to reach the plasma the targeted plasma concentration in the blood to maintain the adequate anesthesia and analgesia. So we use TIVA TSI pumps. This is the changes of target concentration. This is target concentration of our drugs, propofol or remifentanil. If we use target plasma concentration, we shoot up initially, that it will maintain, and then every time we change the concentration, it will shoot up at a certain level, and then after that it will maintain, so that a constant infusion concentration of drugs throughout the surgery can be maintained, to maintain adequate depth of anesthesia, as well as to maintain cerebral protection to the brain. So assuming this is a decompressive cranectomy, while our neurosurgical colleague will remove the skull and then also the dura, so that the brain got the space to expand, the ICP can be reduced. Okay, so later on they will do cranioplasty after some time when the patient recovered. So this is important aspect of the management for high ICP. What actually Brain Trauma Foundation guideline mentioned in their recommendation, okay, about decompressive cranectomy. Bifrontal decompressive cranectomy is not recommended to improve outcome. If you do very as a bifrontal decom, it's not recommended to improve the outcome as measured by Glasgow outcome scale extended score at 6 months post injury in TBI patient. Okay, and with ICP elevation to value more than with ICP elevation to values of more than 20 meter mercury for more than 50 minutes within 1 hour period, they are refractory to first line therapies. Okay, it's actually it's not to improve outcome, but actually to reduce the ICP basically. And however this procedure decom actually aiming to reduce the ICP and minimize days in ICU. For the long-term outcome, possibly it doesn't show much an improvement, but to reduce the ICP and to minimize days in ICU is highly recommended. Large frontotemporal parietal decompressive cranectomy, not less than 12 times 15 or 15 centimeter diameter is recommended over a small frontal. So actually, this is they recommend the large frontotemporal parietal decompressive cranectomy based on the Brain Trauma Foundation guideline. What's an important management at a neuro ICU level? After decompressive cranectomy, commonly patient will be transferred to neuro ICU, or in USM setup, it can be transferred to trauma ICU as well for intensive care monitoring, as well as for the management of ICP. Right. At the neuro ICU level, normally we do cerebral protection strategy over 24 hours by monitoring the ICP, aiming the ICP, because we got the ICP monitoring at this moment. So it is ICP guided monitoring, aiming ICP less than 20 millimeter mercury, CPP 60 to 70 millimeter mercury. So MAP about 80 to 90 depends on our CPP and ICP. PaO2 more than 60, that is very low limit, but normally we keep higher, about 80, 100 millimeter mercury. So we want patient to have a good oxygenation. PaO2 we keep normotensive. Glucose level, we avoid hypoglycemia or hyperglycemia. The temperature, normally we try to avoid, because if a very high temperature because of fever or because of non-infectious fever, one of the common things also that can happen to the patient with traumatic brain injury or patient with high ICP, patient can have a dysfunctional hypothalamus, which can cause non-infectious fever, where the temperature is increasing, not related to the infection. So normally we have to deal with that because when hypothermia, it can cause an increase in CMRO2, and this also we can, when CMRO2 increase, cerebral pulse will increase. This can cause a secondary insult to the brain as well. So another important thing is to monitor the input-output balance, because excessive positive balance, like we resuscitate too much in operation theater or at ED level, from ED to operation theater, so much fluid and blood given, so positive balance is too much, so it can actually worsen the cerebral edema as well. So we need to look at this as well to balance between input and output with the requirement. And at the same time, sedation, normally propofol and fentanyl will be started. Seizure prophylaxis, fluid therapy, as we have discussed just now. And nutrition is very, very important aspect. This is not part of ICP management, but it's a part of ICU care management, because providing the nutrition is help for recovery of the patient. And vasopressor is part of our management to maintain the perfusion pressure. This is the principle of neuro ICU management in our patient. Okay. Right. Another recommendation by Brain Trauma Foundation guideline, they mentioned about seizure prophylaxis. The recommendation mentioned about prophylactic use of phenytoin or valproate is not recommended for preventing late post-trauma seizures, but phenytoin is recommended to decrease the incidence of early post-trauma seizures within 7 days of injury. Okay, so that's why immediately patient admitted to neuro ICU, the phenytoin will be initiated earlier. Right. This is EVD. Normally, EVD is this is how the EVDs looks like, and they are monitoring zero at this level, so that we can monitor the ICP as well as for the CSF drainage when needed. Right. This is the example of the waveform of the ICP. This is normal ICP, less than 20. If ICP increasing up to 20, you can see the B wave, the spike like this, the B wave or ICP. This is very, very high ICP. When ICP markedly increase up to 40, up to 80, you can see this is the A wave of ICP waveform. Right? If let's say after 12 hours of cerebral protection, ICP is actually increased and sustained at 30 to 40 millimeter mercury for our patient. So patient develop persistent and possibly refractory high intracranial pressure management. So we need to look at the few recommendations at the level by Brain Trauma Foundation guideline. They mentioned about cerebral fluid drainage. So the recommendations mention that an EVD system zero at the midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than intermittent use. So it's actually continuous drainage, one of the management to reduce the ICP. So another important, as we discussed earlier, in the patient in the refractory intracranial hypertension, we can initiate the hyperosmolar therapy again. And normally at this level, hypertonic saline is the choice. We commonly use 7.4% hypertonic saline, slow infusion, about 30 mL per hour over 24 hours, followed possibly up to 48 hours, and subsequently gradually weaning to half of the infusion rate later on. We can maintain the hypertonic saline over 24 to 72 hours, and monitoring of serum sodium is very, very important. and once serum sodium reach 155 to millimole per liter, then normally we will stop the infusion of hypertonic saline. And serum osmolarity monitoring is should be done regularly to avoid overshoot of serum osmolarity more than 360 milliosmol per liter. And another important aspect at this point, when the ICP is refractory, we can initiate a barbiturate coma therapy. And theoretically, some mention about induced hypothermia, because to induce hypothermia therapy, but this is not commonly done. Normally at our setup, we use barbiturate coma therapy by give a loading barbiturate. Thiopental is a commonly used barbiturate for this for coma therapy. So we use give a loading dose of thiopental maintained by infusion and guided by this monitor, aiming at bispectral index monitor scale at 20 to 30, where there is the level of burst suppression. So it's actually burst suppression is actually we want to relax the brain and inactivate the brain at a certain level where we don't want it further worsening of the brain injury. So barbiturate coma therapy is another stage of management when the ICP is refractory to the therapy. And then some center they still induce. Sometimes we use both. In very bad cerebral edema, we induce both hypothermia and barbiturate therapy as well. So this is burst suppression. We can see this is our goal. About it's a BIS-30. It's about this is general anesthesia. In operation theater, normally we maintain about 40 to 60 for adequate anesthesia. For burst suppression therapy, we maintain about 20 to 30. This is burst suppression. It's just intermittent increase in the oscillation, followed by isoelectric, maintain high oscillation, and with isoelectric. This is a burst suppression where we aim to achieve during barbiturate coma therapy. This is a BIS monitor we commonly use in operation theater for depth of anesthesia monitoring. We can use this for sedation monitoring, and we can use another tech to use for barbiturate coma therapy monitoring. And this is some recommendation mentions in Brain Trauma Foundation guideline on barbiturate. So administration of barbiturate to induce burst suppression measured by EEG as a prophylaxis against the development of intracranial is not recommended. We don't start barbiturate as a prophylaxis, but we start as a therapy to refractory intracranial hypertension. So high-dose barbiturate administration is recommended to control elevated ICP refractory to maximum standard of medical and surgical treatment. Okay, so there is a very, very important. Although propofol is recommended for the control of ICP, it is not recommended to improve in mortality 6-month outcome. So for propofol, there is some limitation as well. Okay, if we use very prolonged high dose, it can possibly we need to think of the complication like propofol infusion syndrome. Okay, the barbiturate coma therapy is not a magic therapy for refractory intracranial hypertension. So barbiturate coma therapy also has many side effects as well. For example, it can cause, when you initiate barbiturate coma therapy, it can cause severe hypokalemia. If you stop abruptly after you stop the therapy abruptly, it can cause rebound hypokalemia. It can cause increased risk of nosocomial infection as well. So this is one of the few common complications. And at the same time, barbiturate coma therapy, the recovery of patient you expect too long. In days, if you really want to expect the thiopental will be cleared from the body totally, so that you can assess the GCS clearly without any sedative effects. So it's not the therapy without side effects or complications. Okay. What about prophylactic hypothermia? So actually, prophylactic hypothermia within 2.5 hours or short term, prophylactic is not recommended. Okay, the guideline mentioned about the level of guideline mentioned about is not recommended for prophylactic hypothermia in the patient with high ICP. So I just show this is one of the equipment when we can do guided endovascular cooling method for the patient. Let's say very normally some of the neurosurgeon will induce this mild or moderate hypothermia in very bad patient, we can try, because the principle is that low temperature, we can reduce CmO2. It will rest the brain. Okay, if rest the brain, it can reduce the blood flow. But clinically, it's not much evidence showed is clinically the clinical benefit of that. But if you look at the by physiological basis, hypothermia, a mild or moderate hypothermia will help the brain to relax. Okay, for the recovery. So another option by our neurosurgical colleagues, they can think of the next expansion of the cranial wall or decompressive craniectomy to help further reduction of ICP if necessary. This is by the decision of the neurosurgeon, right? Another important general and additional factors we need to remember is that the impact of time from injury to surgery. We can imagine from the pre-hospital care to ED care, patient going to radiology department for CT scan, and then going for surgery before coming to the neurologist. So this is very long time. If we can shorten the time at any point of our management, we can expect the improvement, the recovery, the functional recovery of the patient can be. This is one of the article mentioning about the time from injury to surgery is important factor for the functional recovery of comatose, traumatic acute subdural hematoma patient who underwent surgery. So if we can at any point at our level, either at the ED level, hospital, OT, neuro ICU, we can improve of the time management in management. Possibly the recovery is very important. Okay, if you look at, for example, at my local center, we can see that if you look at the MVA side, patient has been patient spent about 2 hours, and then possibly at the Lebuh Raya, the highway there. So patient normally will send to hospital Gua Musang. So it take 3 hours for the management there possibly, and then transportation from Gua Musang to hospital USM is about another 3 hours, and ED possibly about 3-5 hours with all many things, stabilization, CT scan, and so on. So actually, patient is about 13 hours before we can do some decompressive cranectomy or evacuation of clot, cranectomy evacuation of clot for the patient, and the surgery will take another 3 hours, about 3 to 4 hours here before patient can go for cerebral protection, stabilization, recovery in neuro ICU. So actually, it's so much time taken. So if we can shorten at any point our management, possibly we can expect better recovery to our patient. And at the same time, we must aware and alert the management during transportation. So many transportation for our patient. Transportation from accident scene to the district hospital, from district to the tertiary, from ED to CT scan room, from ED to OT, from OT to neuro ICU, from neuro ICU to CT scan room. So many transportation. Sometimes we take it for granted of the management during transportation, because sometimes patient can develop hypoxia, hypercarbia, BP shoot up, fluctuating from movement, and this actually at any point of insult during this transportation, it can cause worsen condition or secondary insult to the brain. So very important at any level of our management. The management during transportation is very important aspect we need to remember, and we need to care, and we need to protocolize properly. Okay, and as a conclusion, it's a take-home message from me. The ICP management is a multi-level and multidisciplinary, and all levels must synchronize the goals of management for good outcome. This irrespective from pre-hospital, ED, operation theater, anesthesia team, and there's neurosurgical as well as anesthesia at the ICU level. And immediate management of primary insult and continuous cerebral protection from secondary insult are very important management to us. So if anybody interested to listen about barbiturate respiration therapy or neuroprotection, the next week on the same time there's another webinar by neuro anesthesia team on perioperative neuroprotection. You are welcome to listen to the webinar. And at the end, today is actually 16 October, which is Anesthesia Day, celebrating at the national level. So I'm celebrating with you, ED colleagues, to deliver the topic and to sharing my knowledge on ICP management. With that, thank you very much for your attention.
Thank you very much, Prof. Nazaruddin, for the very interesting sharing and enlightenment session. And happy World Anesthesia Day to Prof as well.
Yeah, thank you, Charles.
Okay, so there's some question posted in the chat group here. I will read it out now.
Yeah.
So so I'd like to ask about seizure prophylaxis in traumatic brain injury and massive MCA infarct. Recommendation is not to start for primary prophylaxis. However, I see that some of my neurosurgical colleagues would start for primary prophylaxis. What is your take on this matter?
Yeah, so actually I mentioned in the brain trauma foundation guideline, so prophylaxis for late post-trauma seizures, but for the recommendation is actually to start prophylaxis for early post-traumatic seizures. So actually it's just highly recommended. This is a level 2B recommendation for within 1 week to start some prophylaxis for any traumatic patient. So normally they will start because there is a brain trauma foundation guideline mentioned about for early, the risk of early seizures is very high compared to the late seizures. So during the primary insult and within 1 week, normally we start phenytoin as a main anticonvulsant therapy. Okay. So at any point, patient with brain injured, they got a lower threshold to develop seizures at any point. So actually, I think prophylaxis is very, very important. If you look at you go through and the recommendation back, it's actually is mentioned is highly recommended for early prophylaxis. But for the late seizures, it's not recommended to prolong until months or for the pregnancy, for example, but within 1 week, for 1 week therapy. Yes.
Hi, Prof. Sorry,
Yeah.
that question was from me actually.
Yeah.
The one that you mentioned about highly recommended, is that for primary or secondary prophylaxis?
Primary.
Oh, the primary. Okay.
Yeah.
How about cases like, non-traumatic brain injury? Let's say patient have a massive MCA infarct.
Right.
Patient
Yeah.
don't have any seizure. Will you actually start anti-seizure prophylaxis?
Okay. That one normally actually that brain trauma foundation guideline is referred to the trauma related brain injury. Okay, in any trauma related brain injury, they recommended to start prophylaxis. But for the infarct, for example, it's not necessary where they start. It depends on our neurosurgical colleagues normally. They look at the condition. It's not like a must like in the patient traumatic in the patient with the traumatic brain injury. So the recommendation is mainly for the traumatic brain injury patient. So normally they will straight away start with the IV phenytoin. Okay.
Any study for any other anti-seizure medication besides phenytoin, like Keppra, for instance?
Yeah, so Keppra is not that's mentioned about the Keppra. For instance, Keppra is still not. I mean, no strong evidence to suggest Keppra as a replacement to phenytoin at the point. So actually, but normally, what in the common practice, they always give put it phenytoin as first line. So Keppra normally later on they will replace if let's say patient develop liver impairment later on. Normally patient on phenytoin after a few days, 5, 6, 7 days, you can see some liver impairment. So normally if patient reach that point, then we will change to Keppra.
Yeah. And then I think the next question is also from me. Maybe I just ask you directly, Prof.
Right.
Yeah. So in traumatic brain injury, is when you want to induce coma with anesthetic agent, right?
Yeah.
You say you want to aim for burst suppression.
Yep.
In case of status epilepticus, last time we used to say we aim suppression of 10 seconds, but there are studies shows that there's increase of mortality. So nowadays for status epilepticus, we aim for a shorter suppression, like 5 seconds. But I'm not very sure about coma in traumatic brain injury. Do you all have a specific target for the suppression duration?
Yeah. Okay. As I mentioned, I don't elaborate too much on that. Okay, we call it barbiturate coma therapy or thiopentone coma therapy. See, we aim for burst suppression. So actually, ideally we have EEG to guide our management. We induce loading dose of thiopentone and maintain with the infusion, aiming for EEG to reach the burst suppression. But for EEG, sometimes we need the with the help of our neurological colleagues to have guided or neurosurgical colleague for the EEG. But we have a simplified version of EEG, which is a bispectral index monitor. If you're familiar with bispectral index monitor, you can just put the sensor over the forehead. It's a simplified version. They got the scale from 0 to 100. So normally we titrate our thiopentone infusion to the burst suppression level, which is 20. You see, the scale of 20 is actually the scale of burst suppression. So if we can achieve the 20 to 30, is actually we achieving our target to induce burst suppression or coma therapy to the patient, so that we can rest the brain in a very high ICP condition.
The 20 to 30, is it like 20 to 30 seconds?
No,
or it's other style of scale?
It is a scale. Is it the scale? Okay. Is the
scale?
It's
a scale.
Okay. Scale. Okay. For the bispectral index monitor, which is commonly used by anesthesiologists in operation theater, they come out in the monitor as a scale 0 to 100. Normally for anesthesia, we maintain the scale of 40 to 60. That is very good anesthesia. For sedation, normally about 60 to 70. But we go very deep anesthesia, it can reach very low level, which is 20 to 50 is a burst suppression. So you want to achieve the barbiturate coma therapy. So we go very deep up to 20 to 30 scale of bispectral index monitor. If you're interested, then you can look the scale. Then on. Yeah.
So the next question is: once you achieve burst suppression, how long you will keep?
Okay.
48 hours, 72 hours, or longer?
Yeah. Okay, it depends on the severity of ICP, but normally we don't go longer than 72 hours. Okay, normally 24, about 3 days lah, basically. So by 48 hours, we rest the brain and slowly and gradually we wean. Okay, let's say we on thiopentone infusion after 48 hours, even though possibly ICP doesn't reduce markedly, for example, but we still be weaning slowly. Over 72 hours. It's about 3 days of therapy.
Okay. Thanks, Prof.
Right. Okay. Thank you.
Prof, I have few questions to ask.
Okay. Yeah.
Right. I'm very interested with the TIVA. I think when I did my training in USM, I came across this, but of course at that time I was quite clueless. How different is this from the normal, infusion that you give a patient if they are intubated in the emergency department? Is it the one that you set off is a real time?
Yeah.
How much the drug is running in the patient's body? Can you clarify on that?
Right. Okay. So actually, okay, if you start, I keep on highlighting about the propofol and fentanyl infusion as a main sedation for traumatic for high ICP patient. Even in at the level of emergency department, okay, I recommend you to start sedation level, the dosage at the sedation level for propofol, which is 0.5 to 4 milligram per kg per hour. It's a manual infusion. You calculate 0.5, let's say 70 kg, about 35 milligrams, so 3.5 mils per hour, up to 4 milligram per kg, which is 70 times 4, up to 28 mils per hour. So you can titrate according to ICP. There is actually the sedation level, the dosage for sedation using propofol. Okay, but normally for anesthesia level, total intravenous anesthesia, normally we go higher level. We use manual infusion. So normally we can in operation theater for the sedation, the limit 4 milligram per kg per hour. Normally for anesthesia, we can go up to 6, 8, and 10 milligram per kg per hour continuous infusion. Okay, but that is for manual conventional infusion. But as I mentioned now, the technology has been advanced. The propofol can be delivered by target control infusion. There is a special pump. We don't need to calculate based on milligram per kg per hour. Okay, because the pump has a software based on the pharmacokinetic of propofol. They will deliver depends on how much concentration that we want. Normally for anesthesia, we aim about 3 to 6 microgram per mil. So we set, let's say we want to achieve 4 microgram per mil. So we key in the body weight, we key in the age. Okay, for the patient depends on the model, MASH model. So when we set up, okay, we press the start, the pump will deliver certain infusion rate, and then it will maintain that concentration of propofol within the patient. Because this is based on they make it the pharmacokinetic model based on the study. They take a population of patient, they give it certain boluses, they draw the blood test. This is the concentration. So actually, the pump has done many things to us. Actually, the TIVA. But even the target control infusion pump can be used at the ED level. In fact, used for sedation. For sedation, normally, if we use TCI pump, is actually titratable. You don't need to calculate. You just need to key in certain what you will deliver. So another drugs that in operation theater we use TCI is remifentanil. So it's actually normally for TIVA we combine propofol and remifentanil. This is good combination. You got synergistic effect. It's good for total intravenous anesthesia. For the target control infusion remifentanil, they got a Minto model. It's a different model, different pharmacokinetic model based on remifentanil. So actually it can be used as a sedation as well. You can titrate. Normally we go to lower target plasma or target effect concentration. So you need a different lecture to mention on the target control infusion. But I think it is a good introduction at the ED level as well, because the pump is easily available. You need to understand the concept of target control infusion. How can be delivered? How can be used as a sedation?
Oh, very
at the
interesting.
level. Yeah.
Okay. So it means that the pump itself will the level of the sedation or the drug which is being given to the patient, it depends on the patient's pharmacokinetics
Kinetic,
itself.
yes,
So it's
yes.
individualized.
Individualized.
Oh, okay. All right.
Because they got the software. We just need to put in that, and then they will individualize how much we give it. But at the end, we achieve the target plasma concentration of the drugs for that patient. Same.
Okay.
Like we want to achieve 4. Possibly to other patient, it depends on that patient body weight, that patient gender, and so on. They give the different rate of infusion. But at the end, in the patient, we check the blood, we will reach about that our target plasma concentration.
Okay.
Right.
I think in regards to propofol again, quite a number of people are not really comfortable to it because of the belief that we might induce propofol infusion syndrome.
All right. Yeah.
So is the upper level of the safety of using propofol as an infusion to sedate the patient for mg per kg is okay while
okay.
waiting for
Right,
it's
right.
okay.
It's
But
okay.
it is not advisable to go beyond that if the
Yes.
patient is fighting and so forth.
Yeah, okay.
All right.
It's actually propofol infusion syndrome is not a common complication. It's not common complication. It's not that once you start propofol infusion, then patient commonly develop propofol infusion syndrome. Even in neuro ICU, I can say very seldom happen, and it easily anticipated. Okay, once you monitoring instead, it's not happen very fast. So there is a risk of patient that can develop propofol infusion syndrome. For example, in the pediatric patient with some inborn error metabolism to the lipid, for example, or you give very high concentration, more than 4 milligram per kg per hour for long duration. For example, more than 48 hours. There's mention about the risk of the patient can develop. But in ED, it's a very short stay. You maintain cerebral protection 24 hours, for example. It is still very, very safe. The most important thing, don't worry about propofol infusion syndrome, but concern about protection of the brain. To me, yes, that is the more important. Right.
Okay, all right. But can I continue asking? Does anyone else want to ask? Okay.
Sure, Nina, go ahead.
All right. Regarding hyperventilation in patient with traumatic brain injury as a temporary measure to reduce the ICP, I know in operative intervention, before you open up the skull also, I think some anesthetists will do it. But how about from ED? If let's say we are to do this at the emergency department and we know the patient is going for operative intervention, what will be the duration desirable before you perform it, or it is not recommended at all? Just maintain normal carbia for the patient.
Yeah. Okay. To me, at the ED level, we do not know the ICP roughly. but we assume if patient is very poor GCS, for example, intubated with poor GCS, we know roughly it should be, and then the injury is still there. It's not evacuated the clot with the subdural, the extradural, and so on. So we expect ICP is more than 20, isn't it? I think at the point, the most important thing I say to me is actually to maintain the CPP at the high level. To maintain CPP, that means you can raise up the mean atrial pressure to maintain the CPP at the same time. And if you think you want to transient hyperventilation, okay, it should be within a short duration. Okay, you can do over 15-20 minutes acute hyperventilation, aiming about not less than 35 millimeter mercury. Okay, and then but we don't have a guided monitoring, is that just for the sake of clinical assessment. Okay, and slowly after that you gradually from after you achieve about 20 minutes of hyperventilation with 25 millimeter mercury of PaCO2, later on gradually you should go back to normocapnia, maintaining normocapnia for the surgery. Okay, it's not prolonged hypocapnia. Right.
All right. Okay, thank you, Prof.
Yeah, Prof.
Yep.
Prof, can I ask questions some more?
Boleh. Can.
Boleh ya? Okay.
Yeah, can.
I think I missed out on the hyperosmolar therapy.
Right.
You know, when you want to give hyperosmolar therapy, there's always this, either you choose hypertonic saline or mannitol.
Yeah.
So what is your take? Which one will you prefer? Because there's always these two school of thoughts, you know?
Yep.
Yeah.
Okay, I agree. Okay. Normally another paper mentioned the first line always go to mannitol first. You can try mannitol first, right? But you have to look at the hemodynamic as well. If patient hypotensive, for example, okay, if patient at the same time hypotensive, to augment, I think if you give mannitol, patient will crash. Okay, the blood pressure will crash. So at that point, hypertonic saline is better because hypertonic saline won't cause any crash of blood pressure. Okay, it actually augment the blood pressure. So at that point, you have to choose hypertonic saline is better to aim for reducing cerebral edema, as well as actually to maintain the hemodynamic. So you can choose 3% normal saline, okay, given over 15 to 30 minutes, right? Okay, slow infusion. So I think you have to look at hemodynamic as well as hemodynamic is the most important things. You can choose either one, but if hemodynamic is okay, possibly you can go for mannitol first. Mannitol first, then you can consider the next step is hypertonic saline.
So if it like, how to say, it's very individualized, right?
Yes,
case by case basis.
Yes, case to case basis. As long as you understand about the benefit of hypertonic saline and mannitol. Okay, both actually can be used, but some paper mentions really you should try hypertonic mannitol first, then followed by hypertonic saline. But in the condition where hemodynamic is unstable, if you put mannitol, patient will crash, then hypertonic saline is the first choice. Okay, I think at the ED level, possibly 3% normal saline is good enough already. It's not all center got 7.4 or 23.4% hypertonic saline, unless or in your protocol you has put up that as a part of the management has been prepared for that. I think it's good to have hypertonic saline. It's good to have hypertonic saline because actually the use of hypertonic saline is actually from initial study is actually at the ED level. Okay, at the ED level when the patient coming with hemodynamic unstable and at the same time cerebral edema. So actually one of the initial study, they starting hypertonic saline for that reason to aim to achieve that goal. So that is one of the earliest study of hypertonic saline. Actually.
Yeah, I think
the other thing is the.
Can you just add up
sorry,
a
you
bit?
go on.
No, it's okay. It's okay. It is good to have this kind of discussion actually. So, as for me, I think yes, if the patient coming with trauma, I need to transfuse blood and all, I would try to avoid mannitol as much as possible. Yes, but if let's say the patient is, having quite a normal BP, young patient, then I would incline towards using mannitol.
Yeah.
So the last question for me is, there's always this teaching from my senior say that you have to elevate the patient's head 30 degrees, something like that.
Yeah.
I mean, how far is it? Is it really effective
Okay. Yeah.
without
The-
without proper ICP monitoring? I
yes.
mean, without intracranial monitoring, how effective is this elevation 30 degrees?
So I think actually it is physiologically effective. First, actually, because we put the head up,
Yeah.
actually is actually physically draining the vein, draining the vein, so that it can cause even though the brain is edematous, the venous drainage is not impaired, so it can help. Let's say you put at the supine, or sometimes we put tilted, it compress the vein, so it causes a backflow at the same no drainage, it can worsen the cerebral edema. So actually, the conventional teaching is that is help, even though
It
without
helps.
ICP monitoring. So that is the most we can do without ICP monitoring, to put the head up, okay, and to prevent compression. Understand? Right. Because jugular drainage,
Yeah.
all the drainage of the vein from the head actually going down. So if we compress or if actually we lift up the drainage, we facilitate the drainage.
Yeah. Sounds good.
Yeah.
Thanks.
Okay.
Okay, Prof. There's a few questions from me. What is your view on using ketamine as a RSI agent in increased ICP patient?
Yeah, I anticipate this question basically. Okay. I know. This is a quite contradictory and sometimes to say controversial issues using ketamine at the same level. Okay. There's a paper, I know, there's a paper mentioning about safe to use ketamine because from the conventional teaching that ketamine can cause an increase in ICPs, MRO2, and so on. Whereas that study showed clinical evidence doesn't show so. So actually, it's difficult to prove with the clinical evidence sometimes, and because so many factors. So it's a multifactorial confounding factors to determine that. But I always look at the pharmacological principle of that. We know that ketamine, the ketamine effect is actually it causes increase in cerebral flow and increase in CMRO2. So to me, I try to avoid at all because to me, I don't want at any point give an insult to the brain with that. We do not know what's going to happen inside. But at the end, we look at the end of the clinical evidence where actually there is so many other factors that confounding the result basically. But as long as if we apply our pharmacological knowledge on that, and we know that ketamine can at any point increase MRO2 and increase in the cerebral blood flow, I try to avoid. That's why I know the principle. Unless let's say you think you give a propofol, but you expect hypotension a little bit. So I always in neuro ICU will put noradrenaline to maintain the cerebral perfusion pressure. So we get the benefit of propofol for cerebral protection. So we use vasopressor to increase the cerebral perfusion pressure. That's the things. Let's say some people use Ketafol, which is ketamine plus propofol. The reason that we got the benefit of that to minimize the things. But actually, we actually diluting the benefit of others actually of the propofol. You are actually up, you switch it down, you are actually putting at the level to me. Okay. So that is my point of view basically lah. But you looking at evidence based, there's some paper mentioned about it. There's even systemic review on that. Okay. But I try to avoid with patient. Clearly we know that traumatic brain injury because you have many other ways to do that. Yeah.
Sure, because I think lately I see quite a number of people started using ketamine as a RSI agent for trauma patients.
Yeah, I know. Sometimes you're concerned about patient hypotensive as well as if patient hypotensive without traumatic brain injury, possibly you can consider. But you have to individualize. Let's say that is the best you have to do with a very severe hypotension. Sometimes we have in dilemma in the polytrauma patient, intra-abdominal injury, traumatic brain injury, patient hypotensive crash. You give propofol even for the crash. Oh, I think personally, for me personally, I just will be midazolam and a little bit opioid based rather than you give ketamine. It is safest. The cardiac stable drug is I like midazolam, midazolam, etomidate, or with opioid. This is most cardiac stable. Okay. If you have to cardiac stable at the same time to preserve the effect to the brain, then possibly that is the choice. If you ketamine, okay, you can increase the BP. but at the same time, the brain possibly can be affected as well. So that's why we have to bear between the risk and the benefit of that. Okay. Right.
Prof, another question from me. What is your take in treating hypoglycemia in a traumatic brain injury patient?
Okay.
Because as we know, we need to use isotonic saline.
Right.
But what if the patient concurrently having hypoglycememia, which might reduce his GCS as well, and we need to treat?
Okay. If patient is hypoglycemia, then if patient is clinically hypoglycemia, then you give boluses of glucose therapy. Yeah? One high concentration of glucose. Then you can monitor at least hourly of your hourly. It's not that continuous infusion. It's not continuous. You boluses correcting, then you monitor. You give another boluses. That is actually to me clinically I recommend such way rather than you keep on continuous glucose therapy, because actually the glucose solution, actually the metabolism of glucose produce more water, and more water produce more cerebral edema. There is another conflicting issues. Sometimes we got so many conflicting things now in our management, but so we have a clinician to bear which way is the best lah, basically. Yeah.
Okay, anyone has any other questions?
Prof, just to add on the child's question, do we give a 10% bolus?
Yes, 10% bolus.
10% bolus rather than giving a 50% bolus for the
I think okay, you can choose. I want depend on severity. At least 10% first. I prefer not to overdo. We just give 10%. We see the response. If not enough, then give another one. Okay. I prefer that way. And then we do overshoot. Sometimes some patient is very reactive. We can then give hyperglycemia some more. Last time in neurocritical care, they advocate intensive insulin therapy for neurotraumatic subs. So that is actually in the era where the sepsis patient, they put intensive insulin therapy. At the end, they found out that intensive insulin therapy causes more hypoglycemia to the patient. It's not good. So instead of we want to tightly control the glucose, it induce more hypoglycemia. So actually, now become more liberal as long as we mentioned less than 10, not very tight glucose. Thanks.
Mana Prof?
Prof terkelak.
Okay. Hopefully Prof can join back.
Yeah.
Tengah short discuss ni. Alamak.
Hey, you guys have this weekly basis, is it?
Monthly.
We have monthly, tak sempat weekly.
Hey, I find it very educational. I need to join more often.
No problem. We have it every
You're welcome to join.
month. Yes, please do so. Prof,
Yeah,
you
Prof is
okay?
Sorry, suddenly.
Never mind, Prof.
Welcome back.
It's too long discussion. Until okay, right.
Okay, Prof. Please continue.
Okay, anything else? Anything else because you all want Q&A?
I think about the
Prof, just now you say about the EEG monitoring in the neurocritical ICU,
Right.
Yeah.
Okay.
Yeah. Can you send me more info about that? I'm actually quite interested, the so-called scale of the burst suppression.
Yeah. All right. Okay. I think at our level, normally if like EEG, normally will be done by either neurology team or specifically on neurosurgical, basically. But at our anesthesia level or ED level, you can you try to familiarize with bispectral index monitor. Okay, it can be used at our level.
The electrode is how they put forehead here, left and right, is it?
Yeah, this is a very simple. Yeah, this is
over the forehead. Only,
yeah, it's a 4-point contact. It's a 4-point contact. Okay, at the forehead. Okay, at the forehead. So actually, it's very easily applied over the forehead, and then we can connect to the monitor. So with the monitor, you simply display the numbers. Okay, the numbers of the level of sedation or anesthesia for the patient. So I think if at the ED level, it's a beneficial. It's a beneficial for you to guide the level of sedation for the patient, especially if we aim for cerebral protection. So actually, it's simply that monitor is actually widely used by anesthesiologists and at the ICU, mainly in the operation theater, basically. Yeah, but I think if it's a portable monitor, you can use that. You can use that.
Yeah, I think I can ask my NS colleague to buy. I'm from Cebu.
Yeah. Actually, NS should be familiar with a bispectral index monitor. Should be familiar with that. Right.
Okay. For your information, Prof, Dr. Ben is a neurologist, not sedation.
Oh, really? Oh, sorry. Again, I'm answering to the wrong person.
No lah, we learn together.
Okay. So yep. I think you at the anesthesia level, actually we use bispectral index monitor. Okay. That is simplified for us lah, simplified EEG. But I think it's a guided. We got the scale there. It's quite easy. It's quite easy. To me, for the patient for cerebral protection, it's basically sometimes we can, if you want to aim deep, we can aim at anesthesia level 40 to 60, or we can go deeper. It's a very bad brain. We can go deeper up to 20 to 30 of scale. That is actually the level of burst suppression, as I mentioned. And actually, I think you can rest or you can maintain at 24 hours possibly. So that's good.
Yeah.
But nowadays there is another advanced simplified EEG monitors. They call it. They got another component which is nausea stimulation index as well, where you can monitor the pain. Stimulation. There's a company. There's a by Fresenius Kabi. They got the we call it Connox monitor. This is another advancement of the simplified EEG monitors. They got two things within one. Yeah, you can look at that as well. Yeah.
I think I'm currently in Sydney. I'm going back to Cebu soon.
Oh,
my
okay.
supervisor, my supervisor actually introduced one type. It's a cap. You wear on it, then straight away the EEG will appear in your phone.
Yeah.
That is about 60,000 Aussie dollar lah. Yeah.
Okay. That for you territory, you should have an advanced one. The advanced one.
Yeah.
For us as an intensive, I think the bispectral is good enough for the certain, so many things we can do. But for advancement or for advance of identifying the epileptic foci and so on, I think there is at the neurology level, okay, to have that. Right.
Yeah.
Okay. Good.
Prof, I have one last question.
Right. Okay.
Today we discuss more about traumatic brain injury, but I've had patients that come in with intracranial hemorrhage. So this patient has asthma, which is contraindicated for you to give beta blocker, which is mainly we use labetalol at ETD level to control the blood pressure so that it doesn't bleed further. So there is a bit of controversial issues in which should we or can we consider other agents such as IV GTN to basically control the blood pressure for this patient. So what is your take on that?
This is for hypertensive bleed lah, basically, isn't it?
Yes,
hypertensive
exactly.
bleed. Yeah. Okay. Always to me in neuro ICU, the best for the brain as well as to control the BP in the hypertensive crisis for antihypertensive infusion is normally we use labetalol infusion. Okay, but in this scenario where the beta blocker is contraindicated, then possibly you can think of that GTN as well, or another one for infusion you can think of vasodilator. Normally in ICU we use like hydralazine, but you must remember this is a vasodilators. It might cause a cerebral vasodilatation as well. Okay, so that is the thing, but you have no choice. Possibly the GTN is a less vasodilator, it's more like venodilators. Okay, you can use GTN instead of that. And then if really emergency that you have no choice to control the BP, it's a vicious cycle. You don't control the BP, it can worsen the brain as well. Okay, brain become edemated and so on. So you have to acutely control the BP as well. So as long as you can maintain the BP systolic 140, 150 is a good enough. We don't go too low, because there is actually acceptable systolic blood pressure for patient in hypertensive crisis with the hemorrhage. So 150, 140, 150 is acceptable. So if you don't have any choice, but let's say if you are protected, doing the sedation as a protection as well, so why not you optimize the propofol at the same time, and then controlling the blood pressure as well. So you're protecting the brain during that acute insult. At the same time, you can control blood pressure as well. Okay, instead of you putting a vasodilators and possibly causing another cycle of cerebral vasodilatation. Another one, you can add in another sedation, where possibly we can add in like dexmedetomidine. Sometimes it can help to reduce the blood pressure as well. And then it won't cause any cerebral vasodilatation. So dexmedetomidine is one of the popular sedative agents, which is alpha-2 agonist in ICU. Okay, there is one of the conscious sedation, sedative agent that produces a conscious sedation, where actually patient is easily arousable. You can ask if you ask anesthesiologists, they should be familiar with dexmedetomidine. Okay, this is same group as a clonidine. So you can use a combination of a propofol with dexmedetomidine as well. You have to avoid vasodilators. Okay.
Okay. So even if you're not a neuro center, the anesthesiologist should have it, right?
Yeah. That is not for neuro center. That is actually one of the common sedative agent that we use nowadays in our ICU.
Okay. All right. Okay. Great.
Any one last question? Anyone? If no, I think I would like to end this session by a very quick sum up that Prof have shared to us today. So Prof has mentioned that shortened time to scene to ICU is very important. Therefore, I think the trauma bypass and trauma activation in ED is very important for us to shorten this time period. And Prof also share with us the right choice of drugs during RSI in ED to prevent the sudden surge in ICP, and also the sudden surge in the heart rate. Okay, and faster put the patient on a neuroprotective strategy, where keeping everything in normal glucose, normal tension, normal oxygen, and normal CO2. And Prof also clear the doubts on all the different controversial issues. So I'd like to thank Prof in the usual manner. Thank you for sharing with us today. We have a lot of questions on the Saturday morning. Sorry for taking out.
Thanks a lot.
Thank you for inviting me.
Very good discussion.
All right. Okay,
Prof,
thanks.
Prof, maybe in future we can discuss about the common metabolic disturbances in neuro ICU, so that we can be more aware of that. It will be good input for all of us. Yeah.
Okay, no problem. Okay.
I think we need to do more of such session. Once every month not enough. Let's do once every week.
Okay.
I think before we end, can everyone pull up your webcam so that we can take a group photo?
Sure.
All right. I will have to do this few times because we quite got. Today is the highest participant, Prof.
Oh, really? Oh,
Yes. We have all over the country, Alhamdulillah. So we are very happy. This is a good start. Okay, so.
We have until Sydney.
Wow.
Oh, from the Sydney as well, huh?
Yeah, from Sydney.
Great.
Thank you. Yeah, thank you for joining.
Okay, all right. So I'm just gonna go.
Welcome.
All right, 1, 2, 3. Okay. All right. Second page. Okay. All right. Second page. 1, 2, 3. Okay. Third page. Third page. Third page. Okay, I only have second page drama yang dah keluar. Alright, so anyway, thank you very much everyone.
I think first page you need to retake. I think more people
Retake
opening
ke?
up. Yeah.
Okay, one more time. Okay, alright. 1, 2, 3. Okay, great.
Okay.
Okay,
Thank
thank you
you.
so
Okay.
much. Thank you,
Okay. Thank you.
Prof. Have a good day. Okay, bye
Bye,
Stay
Prof.
everyone.
safe.
Thank
Take
you,
care.
everyone.
Bye.
Thank you.
Bye.
Okay. Take care.
Bye.
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 Bye.